Good afternoon, everyone. My name is Dudley Robinson. I'm a consultant gynaecologist at King's College Hospital in London, and I'm here in the ICS Live Lounge here at the Madrid 2024 meeting with Professor Carol Bugge, who's a professor of nursing at Glasgow Caledonian University. So this is the Urogynaecology and Breakthroughs in Pelvic Floor session. So I'm going to talk to Carol about the work she's recently presented just this morning in the Best of Urogynaecology session. So Carol, do you want to tell us a little bit about, tell us about yourself first, and then about the work that you presented this morning.
Okay, so my name is Carol. I am a professor of nursing, as you say, at Glasgow Caledonian University. And my research interests tend to focus around process evaluations linked to clinical trials, but I have also led a trial myself. And my work tends to be about women's experiences, perhaps, of the kinds of interventions that they receive. So if I tell you about the TOPSY study we were talking about today, TOPSY was a National Institute of Health and Care Research in the UK funded clinical trial and now 4-year follow-up. So TOPSY was funded in 2017 and we recruited between May 18 and just finished recruiting in February 20.
See, I noticed that just before COVID. That was perfect timing.
That
was so clever.
Yeah. Not planned that way, actually. It was planned to finish about 6 months before, I think. So what TOPSY aimed to do was to identify the effectiveness and cost effectiveness of self-managing a vaginal pessary when compared to clinic-based care for women with pelvic organ prolapse. The original study, as I say, recruited in 21 centres across the UK.
I think we were one, weren't we, in London?
Yes, yep. I think so, yeah. There were 340 women randomised, and we were powered. We needed to get 18-month data, which was where the primary outcome was, from 264 women. So we recruited 340 and actually got much higher numbers than that at 18 months. So we measured outcomes at baseline, 6, 12 and 18 months in the original study, and we were lucky enough to get some additional funding to do some follow-up at 4 years, and that's the work that I've presented here today. The previous work was presented at ICS actually 2 years ago in Vienna. So what the original study found was that women's quality of life was no better or no worse when they undertook self-management as opposed to clinic-based care, but at 18 months women experienced fewer complications than those in the clinic-based care group, and clinic-based care cost less to deliver. And if we now follow that on to 4 years, we had a lower response rate, as you might expect. 4 years on, ethics did require us to go back to get consent from the women again.
Why do you think that was? Couldn't you just...
I'm not sure, because we did originally consent women to to ask them if they would be willing to be approached for follow-up, but ethics took that as we had to go back and actually re-consent them. We'd wanted an opt-out, but ethics required an opt-in, so we had to obviously go with that. And 191 women said they would provide further data at 4 years, and of that 186 did. So the original sample, we got about 55% of the 340 women.
And do you know if there's any difference between those patients that you followed up and the patients who you haven't followed up?
So we know based on their baseline characteristics that the women that we followed up at 4 years were younger. No, sorry, it's the other way around. They were older than those who didn't respond, and they also were more likely to take other. We had an other employment category, and that most likely includes people who are retired or can't work through ill health. So they were more likely to be in those groups. But across other features that we tested, for example, and that included their PFIQ 7 baseline score, there was no statistical differences. But I think we do have a bit more work. Interestingly, in the session, I was asked about, differences in comorbidity, and I think we can look at that a bit more, and we will have a look at that.
Which would be interesting to look at, wouldn't it?
Yeah, and interesting as we go to publish. That sounds like something that's clinically relevant for people.
And I think, maybe for people watching us either live or at home or in catch-up, when you taught the patients how to manage the pessaries, could you just tell us a little bit about that?
Yeah, so it was mainly nurses who taught the women how to self-manage, but we didn't define that. So it was a pragmatic trial, so in King's or, in any other centre. If it happened to be a consultant urogynaecologist or a physiotherapist who did that, then that's the way it was. But what we found was it was generally specialist nurses who taught self-management. What we asked them to do and what we trained them to do was to have a 30-minute support session between the nurse and the woman, and in that session, women were taught how to remove and replace, and they practically did that in the session. So they replaced their pessary, hopefully so that they were comfortable to go home. They were given written information to take with them, and they were phoned 2 weeks later to check, and they were asked in that 2 weeks to remove and replace their pessary at home. So they were phoned to check they could do that. If they hadn't done it within the 2 weeks, we phoned again 2 weeks later, etc., until we knew they could. And then there was also a phone number, which was really important to women. So women really valued having a number they could call if they experienced any problems.
And were they asked to remove the pessary at specific times, or just as they felt?
Again, we asked for a minimum of taking out at least once every 6 months. As you'll know, the evidence of that is quite limited as to what we should have prescribed for that. I think there's some trials going on now, about follow-ups for pessaries, but there was less at the time we started. So we said a minimum of 6 months. Please take it out, clean it, put it back in at least once every 6 months. But we do have some data about how women use the pessaries themselves, and for the 4-year data we've got some of that to follow up.
That would be interesting to see how often they took it in and out. And did you have anyone who just couldn't do it, and this was
absolutely, and I'm not going to remember the exact numbers of that, but there was women who started in the self-management group and crossed over, and it was a fairly significant number. I'm going to not guess at it, but I think it was probably around about a quarter. And
I'm just teasing the audience a bit longer, just to be waiting for those results. But, and I asked you this in the session: estrogen use.
So estrogen use at baseline, we checked between the groups, and it was equivalent. So both groups had women using topical estrogen, but there was no difference between the groups. So it wouldn't have explained any difference between the groups because it was the same.
Perfect. So I think it's results time. So what were the results?
Okay. So at 4 years, the two groups were still the same around quality of life. So, and we tested that as an intention to treat analysis. So we took their original groups, despite the fact care had gone back to centres, and women and I think probably I should say at this point that about 40% of those that were originally clinic-based care had said that they got some self-management training, so potentially we would class them as crossovers between 18 months and 4 years, because we weren't in control after 18 months, what happened then. So, but there was still no difference in quality of life between the groups as there wasn't at 18 months, so we tested that with an intention to treat analysis. We used a couple of on-treatment analyses. Again, there was no difference. We did sensitivity analyses. There was no difference. And because we had no difference at 18 months, we built an equivalence test into our 4-year statistical analysis plan. And I think the fancy language for that is the null hypothesis of difference was rejected, but I think it all means the same, really, that quality of life between the groups was the same. The other probably key findings are that complications difference between the self-managing and the clinic-based care groups at 18 months was statistically different. If you looked at proportion of complications, that was no longer statistically significant at 4 years, although the magnitude, so there was still about 4 points difference between the numbers or proportions of complications that women's experienced.
But no longer significant.
But no longer significant. And we think that's because we dropped below our magic 264 number to 186 in responses. We lost the power. Yeah.
And I think you did an economic analysis.
We did.
As well?
So there was a cost effectiveness analysis undertaken by my colleagues Helen Mason and Sarkis Manukin. And that showed that in line with the fact that we had no quality of life difference, and we tested that using the EQ5D for the health economic analysis. So there was no difference there, but there was a difference in resource use. That was predominantly cited in the 0 to 18 month phase, and it narrowed as we went forward to 4 years, with there not really being any difference between 18 months and 4 years. But the incremental net benefit, which is what the economists tell me I have to say, was £2,240, round about that figure.
So that's what you save by doing
Correct.
Self-management?
Yeah.
Wow.
Yeah. It's quite over 4 years, it's quite
It's
a saving.
significant, yeah.
And at 8 months it was £550, £560, and the modelling suggested it would continue. And they did some on-treatment analysis of the cost effectiveness as well, and in that on-treatment analysis it was suggestive that the self-management group who were self-managing, i.e. were on treatment, were using less resource, but the probability of cost effectiveness dropped, and that was partly because there were 2 or 3 outliers in the self-management group who had very poor quality of life.
Got you. And in terms of what did the women think of this? Have you done any qualitative work to look at which they preferred?
So up to 18 months we had a fairly large scale process evaluation, so we could be confident of things like we were testing the intervention because we used checklists. So we interviewed 36 women at baseline and at 18 months. Unfortunately we didn't get funds to carry that on to 4 years, but women told us whether they got the intervention self-management, whether they didn't, so they were in the control group. And we also interviewed a group of women who were eligible for the trial but chose not to take part, so they weren't randomised. And right across those groups people found the intervention acceptable because of the flexibility it offered, because it offered freeing of appointments for health services for other people. So generally it was seen to be an acceptable intervention. Even
in the people who didn't want to take part in the trial?
Yeah. And a lot of that seemed, so we have those data, we have qualitative data, so there was 20 people in that part of the study, and they talked about, for example, it took quite a long time to get their pessary, a right pessary that stayed and they were comfortable with, and they just didn't want to mess with the status quo, basically, so they didn't, or they didn't want to be randomised, so they were happy with the treatment line they were on and didn't want to move from it.
So another question that I think I asked you this morning, but when we see a patient for changing a pessary at 4 months or 6 months, normally we'll give them a new one. So how did that work in the self-management group?
So in the original trial, if they were randomised to self-management and had a pessary that would need to be changed, so it wasn't silicone, and it's probably worth saying there wasn't differences in the kinds of pessaries the groups had either, they would be given them. So, and it varied by centre. So some centres chose to give them to women, some centres sent them out, and after 18 months it really just reverted to whatever that centre would usually do. So sometimes it was GP, so because we're a UK context, it might be by GP prescription, and it might be just sent out from the clinic.
And the other thing that really impressed me about the results was your conversion to surgery rate, which was tiny. So do you want to say a few words about that?
Yeah, so I think, I'm not going to remember the numbers right now, but I think there was
it's
only
about
3.
1%.
Yes, it was, and I think there was 3 women who, of the 186 who responded at that point, who had surgery rather than.
Which is pretty impressive.
It is, yeah. And there was over 90% still using their pessary of that 186. Now,
which I think I always say to my medical students, if patients like pessaries, they tend to stick with them.
Yeah.
And if they don't, then they'll drop out very quickly.
Yeah.
So summing up as a sort of take-home message for people watching this afternoon, what's your overall conclusion? So
my overall conclusion is that quality of life is not affected by women self-managing. So the adverse events were also very low, although we did have one possibly related adverse event up to 4 years. So it feels though like it's a safe thing, because I think clinicians are sometimes worried about whether sending women out. It feels like a safe thing to do if women are cognitively competent to do so. So quality of life is the same. You're probably going to get some positivity around complications, so women will take the pessary out if they experience discharge and put it back in when it goes away. And it's cost effective, so it's going to cost your service less money. So I think there's a selling point there for our commissioners. And
I think if the patients are happy, they persist with it, and it's saving money, as they say, what's not to like?
And I think probably the last thing I would say though for service is just making sure that there is that contact phone number, so that if women do start to experience symptoms they didn't previously have, they do have a back in to service, and because that was definitely a concern of women's, that if they're fully discharged, do you know what happens if something goes wrong? How do I get back?
So as long as they've got a way back into the service,
somebody to speak to if it doesn't feel quite right. Yeah.
Perfect. Carol, thank you so much for telling us about TOPSY, the initial study, and also the 4-year follow-up. It's absolutely amazing results. So thank you very much.
Thank you for the opportunity. Thank you.
Thank you all for watching. This has been the live lounge from here in Madrid in 2024, and I'd like to welcome you all to ICS in Abu Dhabi personally in 2025. So hopefully we'll see you then.